Dear all, welcome to this lecture. In this lecture, I will talk in details about acute interstitial nephritis. As we know generally that acute interstitial nephritis is characterized by an inflammatory cell infiltrate in the renal interstitium. As I will show you later, the interstitium will be infiltrated by lymphocytes, monocytes, and maybe eosinophils. This is my talk outline. I will start by causes of acute interstitial nephritis. The main causes may be divided into different categories. The main category, as we all know, that we have a very long list of drugs responsible for acute interstitial nephritis in the form of analgesics, antibiotics, etc. But I want to concentrate on two drug categories in this list. The first category is proton pump inhibitors. It is well known now that proton pump inhibitors are main cause of acute interstitial nephritis and even chronic interstitial nephritis, and they can cause chronic kidney disease. And there is an abuse for the use of proton pump inhibitors by the patients and even in the prescriptions of the physicians. The second category that I want to concentrate in this list is the immune checkpoint inhibitors. Immune checkpoint inhibitors are now widely used drugs for the management of multiple malignancies. I will mention their mechanism now. For example, we have the ipilimumab and nivolumab and other drugs used as a checkpoint inhibitors, and they are known now. They are well-known causes of acute interstitial nephritis. What are immune checkpoint inhibitors? At first, what are immune checkpoints? On the T cell, there is what is called the PD-1, and on the tumor cell, what is called the PD-L1. If PD-L1 binds to PD-1 on the T cell, this inhibits the T cell to kill the tumor cell. T cell will not attack the tumor cell. So we need drugs that prevent PD-1 to interact or to bind to PD-L1. And these are the checkpoint inhibitors. The checkpoints or immune checkpoints are the PD-L1 and the PD-1. And we need inhibitors to inhibit the bind of these checkpoints. So we have now anti-PD-1 that bind to PD-1 and anti-PD-L1 that bind to PD-L1, prevent the bind between PD-L1 and PD-1, so T cell will attack tumor cell, destroying it and causing tumor cell death. Not only drugs can cause acute interstitial nephritis, but also infections. A big list of infections that can cause acute interstitial nephritis. Some of them may cause granulomatous acute interstitial nephritis as TB, Salmonella, Toxoplasma, and Epstein-Barr virus. And for sure, we have not to forget autoimmune diseases that cause acute interstitial nephritis as sarcoidosis, Sjögren's syndrome, and TINU. TINU is an abbreviation for tubulointerstitial nephritis and uveitis, and I will talk about it in details at the end of this lecture. What is the clinical presentation of acute interstitial nephritis? First of all, it may be asymptomatic until AKI develops. So the main presentation of acute interstitial nephritis, or the first presentation of acute interstitial nephritis, is or may be acute kidney injury. The classic presentation that we all know and study in all textbooks, that is in the form of fever, arthralgia, and rash, is very rare, occurs only in 10% of the cases. So the classic triad that occurs with the acute kidney injury, the classic triad of fever, arthralgia, and rash, is very rare. And by the way, we can find with acute kidney injury also liver function derangement, liver function tested derangement. The drug may affect the kidney and the liver in the same way. Flank pain is also uncommon and rare. What causes flank pain in these patients? As we say, that there is tubulointerstitial nephritis and edema in the interstitium. Edema in the interstitium may cause renal swelling, and this renal swelling may cause renal capsular stretch, and this capsular stretch may cause flank pain. The history of the causative drug may be present. The drug is usually started 3 to 21 days previously, although there are some case reports that there is delayed acute interstitial nephritis occurring up to 18 months after starting a drug. but these are case reports. And for sure, if the cause of the acute interstitial nephritis is systemic disease as Sjogren syndrome or sarcoidosis or any other systemic disease, you might find the clinical evidence of the associated systemic condition. This is the classic maculopapular rash that is seen in patients with acute interstitial nephritis, especially drug-induced, but we said that it is very rare to be seen. It is seen only in 10% of the cases. What about diagnosis? How we diagnose acute interstitial nephritis? First, you can find an evidence in your investigations for the systemic disease if it is the cause of acute interstitial nephritis. For example, you can find hypercalcemia indicating sarcoidosis. You can do ANA, anti-Ra and anti-Lo to diagnose Sjogren syndrome, chest X-ray and serum ACE to diagnose sarcoid. All of these are keys for the systemic disease that may affect or may cause acute interstitial nephritis. But what about interstitial nephritis itself? About kidney injury itself? First of all, the urine analysis or the urine typistic will be bland. You will not find proteinuria or hematuria, or you may find modest proteinuria less than 1 gram per day, because we all know that it is a case of tubulointerstitial nephritis, the lesion here in the interstitium and tubules, and when tubules are affected, the proteinuria level is low. This is versus, or in the opposite, what is happen when there is glomerular lesion. So the proteinuria here is low, less than 1 gram per day, because the lesion is in the tubules and the interstitium. The presence of microscopic hematuria is rare, but if there is microscopic hematuria, it may point toward a glomerular lesion, and but take care, it may not, because if there is it is very rare to see it, but if there is microscopic hematuria and the full-blown presentation of acute interstitial nephritis, so the case is acute interstitial nephritis. You may find in the urine microscopy eosinophilia and white casts, but again, it is not mandatory to find them. You can find a lot of cases of acute interstitial nephritis without eosinophilia, and also you can find in the blood eosinophilia, but it is not mandatory to find it to diagnose acute interstitial nephritis. And for sure, the erythrocyte sedimentation rate will be high. Regarding ultrasound, this is a case of acute kidney injury, so you'll find the kidneys of normal size, or maybe slightly enlarged. Why slightly enlarged? Because of the edema. We mentioned that there will be tubulointerstitial inflammation and edema that may cause kidney enlargement, so may find an ultrasound increased size of the kidney. Renal biopsy, the reference here, Oxford Handbook of Nephrology and Hypertension, mentioned that it is necessary to confirm diagnosis, but usually from my point of view and the point of view of many literature, it may not be mandatory. If the case is a full-blown acute interstitial nephritis, you may not do a biopsy. But we will talk later about when to do biopsy. But if you did biopsy for this case, what you will find? We will find intense interstitial inflammatory cell infiltrate in the form of lymphocytes, monocytes, and maybe eosinophils. And for sure, the glomeruli are normal. You may find giant cells and granuloma in cases of TB and sarcoidosis. And as in any case of renal injury, if there is interstitial fibrosis, always interstitial fibrosis in kidney biopsy, whatever the etiology of the disease, impacts or is a key for worse prognosis. So if there is interstitial fibrosis, this indicates that the prognosis is poor. Let's go through some pathology images. This is a case of interstitial nephritis. You can find here neutrophils with multiple nuclei, polymorph nuclear cells, neutrophils everywhere. You can find the neutrophils. Also, you can find the eosinophils in these cases. Not only in the interstitium, you can find even tubulitis, inflammatory cells inside. You can find neutrophils and eosinophils inside the tubular wall, indicating tubulitis. And an important point here, normally in normal kidney biopsy, you find that tubules are back to back. The tubules are very near to each other. But in this case of acute interstitial nephritis, you find a severe inflammation and tubular infiltration, and interstitial infiltration. So you'll find the spaces between the tubules and each others They are not more back to back to each other because of the interstitial infiltration and edema. And for sure, the glomerulus is normal in acute interstitial nephritis. In this biopsy, you will find a lot of monocytes, a lot of mononuclear cells infiltrating the interstitium. In this image, you can find a lot of eosinophils, like here, eosinophils. You will find a lot of eosinophils. And here, this circle is encircling a granuloma with a multi-nucleated giant cell. You will find a lot of cells with multiple nuclei, a lot of cells with multiple nuclei, multi-nucleated giant cells, and this may occur in TB and sarcoidosis, as we mentioned. Another pathology that you can find in acute interstitial nephritis, but actually you are not looking for it for diagnosis, because usually acute interstitial nephritis is enough to be diagnosed from light microscopy. On immunofluorescence, you may find the linear deposition of immunoglobulin G in drug-induced acute interstitial nephritis. You can see that tubules here are linearly marked. This is because of IgG. What is IgG directed against? In some references, they mention that the IgG here is antibodies is against a component of the tubular basement membrane, and in another evidence that the IgG is directed against a drug metabolite that bound to the tubular basement membrane. So the drug metabolite bound first to tubular basement membrane, and this is attacked by the IgG. But usually this is not in need to diagnose acute interstitial nephritis. Okay, what about treatment of acute interstitial nephritis? First of all, if it is caused by drug, for sure you have to stop offending drug. And if it is caused by systemic disease, you have to treat the systemic disease. The second point regarding use of steroids in these cases. Actually, there is no one approved protocol for the treatment of acute interstitial nephritis with these steroids. Multiple references with different protocols and different approaches. But I see that the approach here in this book is logic. It says that if the patient is dialysis dependent, and there is an indication for dialysis in the case of acute interstitial nephritis, treat with corticosteroids. If the case is dialysis independent, observe the case for 14 days following stop of offending drug. If there is improvement, continue observation. If no, you can start corticosteroids. There are multiple approaches for, as I said, for the use of corticosteroids. You can use what you like, but usually corticosteroids are widely used. The biopsy may guide you to use steroids or not. How? If in the biopsy there is acute inflammation with interstitial edema, this means acute state and you can use a steroid and you can benefit from them. While if there is fibrosis in the biopsy, this may show that steroids may not of any benefit because of chronicity or affection of the interstitium with fibrosis. So if you will give steroids, do you give them intravenous or oral? Again, there is no specific guideline or approved protocol for treatment. Here in this reference, it mentions that you can give prednisolone 1 milligram per kilogram per day orally and taper slowly against response for 3 to 6 months. But there are another references that mention that you can use steroids IV according to the severity. If the case presentation is severe or if it is dialysis dependent, you can start steroids, many pulse, for 3 days and then give oral steroids. So again, there is no clear protocol or approach for the use of steroids, but no doubt that steroids are highly indicated in many cases of acute interstitial nephritis. The next point that I will discuss is tubular interstitial nephritis with uveitis. Actually, this is uncommon case, uncommon presentation. It affects mainly younger females. Younger females present with anterior uveitis, often bilateral and acute interstitial nephritis, and a very important point that may be separated in time. So if you are treating in your hospital or clinic a case of acute interstitial nephritis in young female, you have to ask her about a past history of anterior uveitis in the form of eye burning and etc. Additionally, there will be weight loss, anemia, increased ESR, and maybe deranged liver function test. The pathophysiology of tubular interstitial nephritis is not well known. Some references mention that there is IgG antibodies against modified C-reactive protein that is deposited in the tissues and causes injury. And for sure, the differential diagnosis of these cases are autoimmune diseases that may affect the eye and the kidney at the same time as Sjogren's syndrome and sarcoidosis. For sure, you will need ophthalmology consultation, and the treatment is usually steroids, 1 milligram per kilogram per day, and taper against resolution for 3 to 6 months, but poorly. The relapse is common, and complete with steroid withdrawal may not be possible. Tubular interstitial nephritis with uveitis is a direct case in clinic or in exams. You can diagnose it easily. You will have a patient with a problem in the eye, and acute interstitial nephritis are the same, so the diagnosis is very easy in these cases. Now we have to go to test yourself. Again, you can pause the video and answer the question before I answer it. Let's start. Okay, this case is a patient with non-small cell lung cancer. He will be treated with a checkpoint inhibitor, and the oncologist asks you about the risk of kidney injury in this case. This case also taking proton pump inhibitors and also taking non-steroidal anti-inflammatory drugs. So this case is taking 3 drugs that cause acute interstitial nephritis. So to decrease the risk of acute interstitial nephritis by checkpoint inhibitors, which it seems that it is the most important drug in this patient, the patient has to stop non-steroidal anti-inflammatory drugs and the proton pump inhibitors to decrease the risk of acute interstitial nephritis. Next case. Okay, this is a direct case of tubular interstitial nephritis with uveitis. You have a case with bilateral redness of the eye, burning sensation of the eye, and the grittiness. Grittiness means that she feels something like sand in her eye. And in the lab investigations, there is high serum creatinine, there is high ESR, the NA is negative, means that there is no autoimmune disease, and there are some eosinophils in urine, so she has also acute interstitial nephritis. So this case is tubular interstitial nephritis with uveitis, and the answer is oral steroids to treat this case. Next case. Okay, this is case of acute interstitial nephritis secondary to allopurinol. The answer is interstitial inflammation with lymphocytes, macrophage, and eosinophils that we will find on biopsy. Why it is acute interstitial nephritis? There is a history of allopurinol. The urine now shows protein 1 plus and the proteinuria less than 1 gram. Virology and immunology are negative. There is elevation in serum creatinine and GFR in comparison with results 2 months ago. For sure, it is not glomerular crescent and it is not red cell cast, because glomerular crescent and red cell cast, as we mentioned in the course of glomerulonephritis later, we present with especially the glomerular crescent with rapid rising of serum creatinine than this, with more red blood cells in the urine. It is not urate crystals. Urate crystals occurs mainly in tumor lysis syndrome, as we mentioned in that lecture, and the urate level now is controlled. Yes, allopurinol may cause intratubular than thin crystals, but the presentation here is usually of acute interstitial nephritis. So what you will find on biopsy is interstitial infiltration with lymphocytes, macrophages, and eosinophils. Next case. Okay, here again, this is a case with omeprazole-induced acute interstitial nephritis. The answer here is to replace omeprazole with ranitidine. The patient is on omeprazole, and there is elevation of serum creatinine, and there is another key in this case that there is hypomagnesemia. Hypomagnesemia is caused mainly by acute interstitial nephritis, is caused by mainly proton pump inhibitors. In urine analysis, you will find the protein 2 plus, proteinuria less than 1 gram. So there is a rising in serum creatinine over the past 6 months in patients who started omeprazole with hypomagnesemia. So kidney injury with low proteinuria and hypomagnesemia in patient taking omeprazole. So usually it is acute interstitial nephritis secondary to omeprazole, and you have to replace omeprazole with ranitidine. Next case. Again, this is a case of acute interstitial nephritis secondary to omeprazole. From where we know, we will find here the creatinine is elevated in comparison to 8 weeks ago creatinine. The GFR is reduced in comparison to 8 weeks ago GFR. There is again hypomagnesemia in this case, low protein in the urine. Okay. And by the way, the urine output here is excellent, and in usually almost all the cases of acute interstitial nephritis, especially second to drugs, the urine output in these cases is good. This may be indicating tubular dysfunction, by the way, especially if the patient has nocturia. So this is a case of acute interstitial nephritis secondary to omeprazole use. Next case. Actually, this is a case not related mainly to drug-induced interstitial nephritis, but it is a case related to drug-induced acute kidney injury. This is a patient, old lady with vomiting and diarrhea, with hypotension, and she is on ramipril and ibuprofen. So in this case, we have to stop ibuprofen because it is nephrotoxic, and ramipril because it also nephrotoxic, as it may cause pre-renal impairment. And by the way, ibuprofen can cause interstitial nephritis and can cause pre-renal impairment by affecting the prostaglandin production in the kidney. So we have to stop both of these drugs and give hydration for the patient and monitor urine output of the case. Thank you for watching this lecture, and see you again in the next lecture.